ChatGPT will be dealt by Dr. Aditya Sethi. He is going to talk about ChatGPT in healthcare. Is it a boon or a curse? So, frankly speaking, I have used ChatGPT to generate blogs for my website, where I was talking about lenses, and just the first, I think, the definition it gave was was there, and everything rest was same for even for toric, multifocals, everything. It was giving the same things. So,
Yeah.
more about it by Dr. Aditya Sethi.
So just to start the talk, I think it's not fair that we are comparing ChatGPT with the human brain, and I don't think it's fair that we're comparing any sort of AI with the human being, because if you even have to compare two people, you have to have them with the same age group at least. So AI is at a very nascent stage. At the same time, AI is made by the human brain, so it will never go above it, because whatever we feed, it'll grow. So it's got to do, it's dependent, it's like a symbiotic relationship. It's not one versus the other as the movies show it. I think it's got to do with both together. Can I have my slide? No? Yeah, so like everything else, it'll have a boon, it'll have a curse. So this talk that was given to me was talking about both sides of the coin. So I'll explain a little bit here, a little bit there. And even though it was ChatGPT, is it in healthcare? I've broken it to a little bit of AI, because I think ChatGPT is absolutely baby. So it's very difficult to compare it or even say it's a boon or a curse at the moment. I have no financial interest, of course, but I did spend some money and got ChatGPT 4.0 for experience sake, for getting this hang of it. And a lot of you have seen WhatsApp, a lot of random posters coming in from me. That's because of ChatGPT 4.0. All right. So basically, AI is just about eyes in the sky. It talks about nowadays where it's really affected already is drug discovery. A lot of drugs which are coming in now have been chosen, or the modifications have been made by AI. So you must have read in the newspaper, new cancer drug has come out and it's looking very promising. Or you must have read that, there's a new type of insulin in the market, or a weight loss, this thing going, which Elon Musk also tweeted. All of that is coming from drug discovery with the help of AI. It's not just AI, it's with the help of AI. It also improves the speed and accuracy of diagnosis. One day I got a call from one of my colleagues who said there's a new EMR. And this EMR, I just punch in what the patient has, and it's telling me what medicines to give. So it was shock and awe. Do you understand? So all of this is coming because of AI, and it's just basically whatever information we give it, it implies. So whether it's correct or not, it's got to do with the fact that we are there, and if we are giving wrong information to it, it will reply in a wrong information. EHR or EMRs as we call it, a lot of data we have, we don't know we have. We don't analyze it because we don't have the time every day. So AI's job is to make it smaller. Robotic surgery, we had a whole debate on it, and yesterday itself there was an article which came that the first vitrectomy by a robot was done in Belgium. So I thought it was one day late because we had a debate the day before, but yeah, great. So clinical trials, of course, there are a lot of talks about AI in clinical trials. So basically, AI is not new. It's been there for a really long time. In 1950, there was the first paper which spoke about can machines think, and it laid the foundation of AI. So it's called the Turing's test. Turing's test is an evaluation of any AI, whatever you use in your day-to-day activities, which compares it with the human brain. It says, does it have even a close to ability to think like the human brain would? So this Turing's test is very important. And basically, the idea of AI came across as just to augment the human brain, not to replace it. So this is the evolution timeline. If you notice, there was a lot of big gap between 1960 and 1997, which is called the AI winter. So here, AI took a lot of beating. It did not do well at all. And then slowly started getting it, do its groove again. And today we have a lot of AIs at the click of a button with us. So AI's impact on healthcare, basically 2 decades it's been used in healthcare. Is data driven from EMRs. Now we have massive data sets. All our glasses have AI in it. So data is going from their watches, your Fitbits. That's all data. And that data, what is the regular heart rate of everybody? Like it's like everybody going through a scan every 5 minutes. And all that data goes somewhere. And AI is one technology of analyzing that and coming up to better things. So ophthalmology is absolutely the best place for AI, because everything we do is data based, image based, and rich in getting information out. Every photo you take, every biometry you do, every refraction you do, everything is data, and that data correlates to something, and that is where ophthalmology and AI come together. So basically, the significance is one of the earliest studies, which was 1970, was a CASNet study. This was basically to find out glaucoma consultation programs with the help of AI. So what we are talking about is as early as 1970. Of course, this was much before the winter, so there was a lot of gaps. And we've all heard of the mycin design of antibiotic to find out which is what sensitive to what. This was one of the most inspiring AI technologies which came out, and that's helped in choosing the right diagnostic tool, the right medicine, the right antibiotic. So again, pointing out that ophthalmology is actually a very good place for AI to be used. Various milestones in ophthalmology. The first FDA approved AI was for diabetic retinopathy called IDXDR. And basically, this is FDA approved in the sense that you don't need a doctor to interpret the results. So that's where AI has made it easy. So this is a good screening tool. Again, I'm still pretty sure in the US and everywhere else, this can't prescribe medicines, but it can take a picture. It'll tell you what sort of level of diabetic retinopathy you have, so that you can go for a consultation or forget about it. That's how it's being used right now. So spectrum today is basically there are three types of AIs. We have ANI, which is narrow intelligence. We have general intelligence, which matches or exceeds the human, and super intelligence, which surpasses, which we're very worried about. It comes in Netflix movies that, oh, that's the end of life. That's how it is. So currently, most of it is just ANI. That's narrow intelligence. That means it requires the human brain to perform. So ChatGPT is basically, we all know about OpenAI. It's been in the news for a long time. It's easy for us. We've all heard articles come out of it because it was so easy. It's basically, I feel it's the iPhone of AI. It's as simple as that. How easy iPhones are to use, right? You can't go wrong. If you delete a photo, it takes 20 more minutes to delete it. And probably 20 more days it'll be in some vault somewhere so that you're sure you want to delete it. That's how easy ChatGPT is. You just put in anything, it gives you a result. Now, most of us need to know how to use ChatGPT to actually get the maximum out of it. And that, I think, is an art itself. It's like a Google search. You can Google search, where do I get good food? Or where you can write food, Calcutta, this place, this place, this place, and you get the best results. And this speaks for itself that how much the market has grown with AI around it. So it's actually being used whether we are on board or not. So ChatGPT in healthcare has various benefits. It has service and other benefits in healthcare. You can implement it directly to your EMR now. You have customization needs, guidelines, resolving, and basically alternatives are being looked at. But what we are really interested in is the deep learning and CNNs, which basically look at images and they give you results. So this is where diabetic retinopathy, ARMD, glaucoma screening, all of this comes into play. And all it does, it takes fundus photos, OCTs, it collaborates the data together and learns how to give you a significant diagnosis. Again, milestones AI, all have been used. Diabetic retinopathy, now we have the FDA approved, which is supposed to be highly sensitive, 87.2% and 90.7. A lot of what I went through articles quoted that this is as significant as a experienced doctor picking up lesions. Glaucoma detection also has been quite sensitive. We have ARMD, which is now a new promising software which is there and is working. So the real world impact, we had the Watson. We know Watson from the Hello Watson shows in the UK. So it's actually been, IBM Watson has been used in personalizing treatments. It personalizes as per the patient. Sometimes you don't have the time to find out exactly about the patient. The AI can help you there. Google AI, of course, we've all had Mr. Sundar Pichai come and talk about how he took one selfie and you could see his scan. So that's where Google AI is doing really well in screening diabetic retinopathy. And there are a lot of new projects coming in because technology is something which grows. This is the diabetic retinopathy screening studies which have been done. The two basic main first two softwares are IDXDR and IART. And they both have shown high specificity and high sensitivity, which is great. Which is a great start actually. And it gets even better. So it makes screening of underserved populations much easier. So say Nikunj could have gone to certain parts of Madhya Pradesh, he would have sent this AI technology with a oriented staff, and he gets a lot of data and he knows exactly which area requires his attention and doesn't. Similar goes for glaucoma detection. It's now coming to smartphones as well, the AI, so that it's less robust for everybody to go in. And in the end, it's basically get minimal and get maximal out of it. So ARMD also, it's already worked. Detection of wet AMD is now started, which is a game changer, because that's exactly when you want your patient to walk in, and that's when you want to give your right treatment and prevent vision loss. So whole idea is to get there where you can reverse the cause of blindness. And of course the curse. The curse is basically leak of data privacy. We always worried, there was a big article in the paper which said that are other companies benefiting from ChatGPT because a company A is giving in data, so it's using their numbers and it's getting its own. So yeah, misdiagnosis or misdata, which is something that Kaushik also threw light on. So I'm going to talk about a few challenges. I'll just take about 2 minutes. Is that fine? So first one is going to be data quality and diversity. So one of the main challenge we have is that it requires large data set, lot of good quality images. You can't have a bad quality image and send it to AI. So solution of this is basically getting a standardized protocol. That is still not established in all of it. If you have a standardized protocol, how to take a picture, where to take a picture, what sort of camera to use, maybe that will override this. The second challenge that it has is clinical integration. A lot of EMRs, we are very comfortable, we don't want to budge from it. So we have to find something which integrates into the existing mechanism, not say, okay, leave your EMR, come to us. That won't work, because that means a lot of changes. Ethical and legal considerations, Kaushik has pointed out yesterday also, or day before also, he pointed out in somebody's presentation, why didn't you give credit, which is absolutely bang on. Because it's ethically right, it's to give credit to if you use anything from anywhere. Similarly, the legal considerations also future. If this data gets leaked, who's in trouble? So all these things have to be ensured. You have to have proper legal framework document which is signed by 3 parties, and then that's how it can look forward. Then most important, I feel, is building trust among patients and professionals. I think this is where a company progresses and it fails, or a system progresses and fails. If you have trust in the system, if you have a transparent system, I think it's easier. But when you don't know where this data is going, how it's analyzing, it's not easy for everybody to interpret in simple words. People don't want to use it. They're worried about what can go wrong. And future directions basically are different disease protocols. We can have integration with areas which are absolutely underserved, so that we can at least reach out to the people, and AI can be used for people who don't have the right doctor, the right medicine for them, and give us data sets if we know exactly where our efforts should go into. Not that we have 10 doctors in one population and we have 0 doctors in another population. So that's where AI makes all the difference. Of course, surgical planning in all AI is still very nascent. Like I said, the first vitrectomy just happened, so it's very different. And there are ethical parts to it. And the synergy is very important. Getting both sides together in a proper baseline is very, very important. And my slides go on. So concluding thoughts. It has already done pretty well. It's shock and awed most of us. That's why we're here talking about it. And we have to adopt it in the right way, get the maximum out of it, and needs further research and development. All right. Thank you so much.
So, thank you so much,
cool
Dr.
Yeah. This is what I've made from
generative AI. I think Dr. Prasanna next will be going to talk about it. Actually, there was a lot of stuff in these slides, and I think each slide will encompass for it warrants a longer discussion. But I'll just take one point out of it, and then I'll ask the panel's opinion on it. Actually, we have been using AI in our daily clinical practice, like in OCT, RNFL. It automatically detects the optic disc margin and the cup margin, and then it gives us it analyzes and gives us the where the thinning is. Actually, it is wrong many of the times, but yeah, but how many of us actually go and correct those data? And if something comes like what he was telling in EMR, we put the symptoms and then it will tell the medicine. How many of us will actually change those medicine and use our brain if it becomes like that? So panel's opinion on that.
I don't think first that it doesn't match. You very rightly pointed out, especially the disc ratio, it doesn't match what we see with the indirect. It really doesn't match. And then we do not go and correct it. We do not do that. So we stick to our findings, and in the EMR, when we are putting down our EMR, we stick to our things. I don't know about the others, but that's what I do.
So I think what we, in healthcare, what we are actually trying to focus on in AI as a whole is probably not wanting the AI to actually prescribe medicines, right? That is not what we want from AI at this point. That is where we want our input. What we want is basically diagnosis and prognostication that can help the patient, and to tell them follow-ups, and basically remote diagnosis is what has to be focused on. So I don't think this is prescribing medicines is what we want from the AI softwares right now.
So very correctly said. The data set is not that robust yet to